Okay, let's unpack this. If you've ever tried to get a handle on complex health topics, especially, when it comes to something as vital and intricate as your heart, you know how quickly you can feel completely swamped.
Oh, absolutely.
Terms like hypertension, dysrhythmias, and acute coronary syndromes get thrown around, and it's easy for them to just become, buzzwords rather than concepts we truly understand.
That feeling of information overload is incredibly common, and yet having a solid grasp of these fundamental cardiac conditions, understanding not just the definitions but the why and the how, is absolutely foundational to understanding overall health. Really is.
Exactly. That's why we're doing this deep dive. You've shared a stack of source material with us, notes and articles specifically focused on adult health, homing in on these three crucial areas: hypertension, dysrhythmias, and acute coronary syndromes.
Our mission today is to guide you through this material. We're going to try and extract the most important nuggets of knowledge, connect the dots between these seemingly separate heart issues, and explore the vital details outlined in your sources, explaining why they matter for diagnosis, treatment, and, well, just your understanding.
We're going to explore what these conditions are based on your notes, how they impact the body at a deeper level, the diagnostic clues, the material highlights, and key points about managing them, all drawn directly from the information you provided. This isn't about general knowledge. This is tailored to your sources.
Right.
So let's jump right in and start with the silent force that affects so many, often without them even knowing it: hypertension.
Absolutely. At its core, hypertension, or high blood pressure, it's about the mechanical force exerted by circulating blood against the walls of your arteries. Your source material gives us a really elegant formula that encapsulates this. Blood pressure equals cardiac output multiplied by peripheral vascular resistance. BPP equals COX PVR.
That formula looks simple. BP equals CO times PVR, but it packs a punch, doesn't it? Let's really unpack what CO and PVR mean in this context, based on your source material.
Certainly. Cardiac output, or CO, is essentially the volume of blood the heart pumps out each minute. Your source breaks it down further, noting that CO is calculated by multiplying stroke volume, that's the amount of blood ejected, with each individual beat by heart rate, the number of beats per minute.
Okay, so stroke volume times heart rate.
Exactly. So how much blood the heart moves overall depends on the strength of each squeeze and, how many times it squeezes per minute.
Okay, so CO is the heart's pumping performance. Then there's PVR, peripheral vascular resistance, the resistance in the system.
That's right. PVR represents the collective resistance within the circulatory system, specifically in the smaller arteries and arterioles. Think of the blood vessels like a system of pipes. If those pipes are wide and relaxed, resistance is low.
Makes sense.
If they're constricted or narrowed, resistance increases significantly. Your source emphasizes this resistance is what the heart has to push against to get blood flowing.
So blood pressure is a product of how hard the heart pumps and how constricted or, open the blood vessels are. And the source highlights that the body has multiple complex systems constantly adjusting these factors to maintain optimal perfusion, getting blood flow to where it's needed.
Precisely. Several systems are constantly interacting in a dynamic balance. The autonomic nervous system, through the release of stress hormones like epinephrine and norepinephrine, can rapidly constrict blood vessels, drastically increasing PVR and thus BP.
Right, the fight or flight response kind of thing.
Kind of, yeah.
Hmm.
And then you have baroreceptors, specialized pressure sensors located in the carotid arteries and aortic arch. They monitor your mean arterial pressure, MAP, and send signals back to the brain to trigger adjustments in heart rate, contractility, and vascular tone.
And the RAS system, the renin-angiotensin-aldosterone system, the source makes a point of noting this system is designed specifically to raise BP.
It's a powerful, multi-step hormonal cascade primarily activated when blood pressure drops or blood flow to the kidneys decreases. Renin release triggers a chain reaction leading to the production of angiotensin II, which is a potent vasoconstrictor.
Ah, so it squeezes the pipes.
Squeezes the pipes, exactly, increasing PVR immediately. And angiotensin II also stimulates the release of aldosterone from the adrenal glands, which causes the kidneys to retain sodium and water.
More sodium and water retention means increased fluid volume in the bloodstream,
which directly increases cardiac output by increasing the volume the heart has to pump. So the RAAS system uses both sides of the BP equation, increasing PVR through vasoconstriction and increasing CO through fluid retention. It's a key player in blood pressure regulation and unfortunately a key contributor to chronic hypertension if it gets, inappropriately activated.
And, as you mentioned, fluid volume status is a direct influence. If you have more fluid circulating in a closed system, the pressure inside goes up. It's fascinating how these systems are supposed to maintain balance, but when they're chronically stressed or dysfunctional, they lead to sustained high pressure.
Exactly. And your source provides the commonly used SCHA classifications to numerically define these states of elevated pressure.
Okay, let's walk through those numbers and what they signify. It starts with normal, right?
Right. Normal blood pressure is defined as less than 120 systolic AND, less than 80 diastolic. So under a 120 over 80.
Simple enough. Then there's elevated.
Elevated blood pressure is when the systolic pressure, that's the top number, is between 120 and 129 mmHg, while the diastolic pressure, the bottom number, is still less than 80 mmHg. This isn't yet hypertension, but it's a warning sign.
A heads up, basically.
Yeah, a heads up that intervention, primarily lifestyle changes, is needed to prevent progression.
And the stages of hypertension itself. Stage 1.
Stage 1 hypertension is diagnosed when the systolic pressure is between 130 and 139 mmHg, or the diastolic pressure is between 80 and 89 mmHg. It only takes one number being in this range.
Just one. Okay. And stage 2?
Stage 2 hypertension is defined as a systolic pressure of 140 mmHg or higher, or diastolic pressure of 90 mmHg or higher. Reaching stage 2 signifies a higher risk and usually necessitates both lifestyle changes and medication initiation, according to standard guidelines, although your source material focuses more on the specifics of the drugs themselves rather than when to start them.
Got it. And then the most severe category mentioned in the source, hypertensive crisis.
Your source defines this as blood pressure exceeding 180 mmHg, systolic or 120 mmHg diastolic, so 180 over 120 or higher on either number. It's a critical level requiring urgent attention.
Urgent. And what your source importantly highlights, and this is often surprising, is that this crisis can occur with or without symptoms.
That phrase, with or without symptoms, really drives home why hypertension is called the silent killer, doesn't it?
Yeah.
You could be walking around with pressures over 180 or 120 and feel absolutely fine while damage is occurring internally.
Scary stuff.
Precisely. It underscores the insidious nature of the condition. And based on your source, we differentiate between two main types of hypertension, essential and secondary.
Essential hypertension is the vast majority of cases, right? Your source says it's not caused by another underlying health problem.
That's correct. It's also known as primary hypertension. While the exact cause isn't always crystal clear, it's believed to result from a complex interplay of genetic predispositions and lifestyle factors. Your source lists many of these: obesity, smoking, chronic stress, a sedentary lifestyle, high alcohol intake, family history genetics, increasing age, and certain ethnicities.
Quite a list.
It is. And over time, the sustained high pressure, driven by these factors, causes damage and thickening or hyperplasia of the arterioles throughout the body, increasing PVR even further.
So the vessels themselves become part of the problem, stiffening and narrowing. What about secondary hypertension?
This type is caused by an identifiable underlying health condition. Your source lists several examples. Renal disease, kidney problems affect fluid balance, and RAAS activation.
Makes sense.
Cushing syndrome, excess cortisol can raise BP. Primary aldosteronism, excess aldosterone production leading to sodium water retention. And pheochromocytoma. These are tumors in the adrenal medulla that secrete excess epinephrine or rapinephrine, causing intense vasoconstriction.
Wow. And your notes specifically mention that secondary hypertension caused by conditions like these is often managed with beta blockers.
Yes, that's a specific treatment note in the material. The approach can differ because you are treating the hypertension that is a symptom of another disease, and beta blockers, by blocking sympathetic nervous system activity, can be particularly effective in certain forms of secondary hypertension, like those caused by excess adrenaline.
We keep coming back to the silent aspect. Your source explicitly states most people are asymptomatic. This is where the danger lies, because the damage is happening behind the scenes. What kind of damage are we talking about?
The sustained high pressure relentlessly stresses blood vessels and organs. Your source highlights target organ damage. These are the vital organs most vulnerable to the long-term effects of hypertension. They include the eyes, potentially causing vision problems.
Right.
The heart, leading specifically to left ventricular hypertrophy or LVH, and the kidneys, impacting their ability to filter waste.
Let's focus on that LVH for a second. Left ventricular hypertrophy. Why does the left ventricle thicken?
Well, the left ventricle is the main pumping chamber, pushing blood out to the entire body. When PVR is chronically high, the ventricle has to work harder and harder, constantly pushing against that increased resistance. Like any muscle subjected to excessive workload, it responds by getting bigger and thicker.
Like lifting weights.
Exactly. While initially it's a compensatory mechanism, over time a thickened ventricle can become stiff and less efficient at filling and pumping, eventually contributing to heart failure.
And the kidney damage. Your source mentions elevated BUN creatinine. What are those?
Yes, BUN stands for blood urea nitrogen, and creatinine are waste products that the kidneys filter out of the blood. If the kidneys are damaged by sustained high pressure, they lose their ability to filter effectively, leading to higher levels of these substances building up in the blood. Elevated BUN and creatinine are markers indicating reduced kidney function, which is a serious consequence of hypertensive damage.
It's clear that preventing this damage is paramount. Your source outlines crucial strategies for managing hypertension that go beyond medication, lifestyle stuff.
Absolutely. Lifestyle modification is foundational, often referred to as risk reduction teaching in your notes. Reducing sodium intake is a major focus. Your source suggests aiming for less than 1,500 milligrams per day if possible.
Why does less salt help?
Less dietary sodium means less water retention. Water follows salt, basically. So less salt, less water held in the bloodstream helps decrease blood volume and therefore lower pressure.
Okay. The DAESH diet is highlighted as well.
The DAESH diet, Dietary Approaches to Stop Hypertension, is a comprehensive eating plan. It's rich in fruits, vegetables, low-fat dairy, whole grains, poultry, fish, and nuts, while being low in red meat, sweets, and sugary drinks. It naturally provides higher amounts of potassium, magnesium, and calcium, minerals known to help regulate blood pressure, and it's inherently lower in saturated fat, total fat, and cholesterol.
Sounds generally healthy overall.
It really is. And then the obvious lifestyle factors. Regular physical activity, your source recommends 30 minutes a day most days, moderate alcohol use, weight loss if overweight, smoking cessation, and managing stress and sleep apnea.
How do those connect back? Like smoke?
Well, smoking directly constricts blood vessels, increasing PVR almost immediately. Regular exercise and weight loss reduce overall cardiovascular stress. Excessive alcohol intake can raise blood pressure. Stress triggers that sympathetic nervous system activation we talked about. And sleep apnea is strongly linked to resistant hypertension, often requiring CPAP therapy for control. Addressing these factors directly influences CO and PVR.
While lifestyle is key, medications are often necessary, especially in stage 1 and definitely in stage 2. Your source lists several common classes used. Let's dive into those and the specific considerations mentioned.
Okay, first, ACE inhibitors, like lisinopril. These block the action of the enzyme that converts angiotensin first to angiotensin second, so they reduce vasoconstriction and aldosterone secretion.
What does the source say to watch for?
Your source notes key things to monitor for. A persistent dry cough, that's a common side effect, and hyperkalemia, which is elevated potassium levels, because ACE inhibitors can affect how the kidneys handle potassium.
Okay. And ARBs, angiotensin second receptor blockers, like losartan. Your source mentions they are often used if a patient can't tolerate ACE inhibitors, probably because of that cough.
Exactly right. ARBs block angiotensin second from binding to its receptors in blood vessels and other tissues. They achieve a similar effect to ACE inhibitors, but through a different mechanism, and that dry cough side effect is much less common.
Calcium channel blockers, like amlodipine.
These medications inhibit the movement of calcium into heart and smooth muscle cells. In blood vessels, this causes relaxation and vasodilation, reducing PVR. Your source lists monitoring for edema swelling, especially in the ankles, due to that vasodilation hypotension or low blood pressure, and includes a very specific and important instruction. Avoid grapefruit juice.
Huh. Grapefruit juice. That seems random. Why?
Well, your source doesn't provide the pharmacological detail, but generally, grapefruit juice contains compounds that can interfere with certain enzymes in the liver that metabolize these drugs and others. This can lead to higher than expected drug levels in the bloodstream, increasing the risk of side effects like dangerously low blood pressure or more edema.
Good to know. Beta blockers, like metoprolol.
Beta blockers block the effects of the sympathetic nervous system primarily on the heart, slowing the heart rate and reducing the force of contraction. This lowers cardiac output. They can also affect blood vessels. Your source correctly lists monitoring heart rate and blood pressure before administration, and crucially, advising against abrupt withdrawal.
Why not stop suddenly?
Stopping suddenly can lead to a dangerous rebound increase in heart rate and blood pressure, potentially triggering chest pain or even a heart attack. Interestingly, your source also lists avoiding high potassium foods under beta blocker teaching, a note typically associated more with RAAS inhibitors or certain diuretics, but something highlighted in your material, so important to note.
Okay. Finally, diuretics, specifically thiazide diuretics like HCTZ and loop diuretics like furosemide or Lasix, water pills.
Right. These drugs increase the excretion of sodium and water by the kidneys, reducing circulating blood volume and thus lowering CO. The primary monitoring point your source emphasizes for these medications is electrolytes, particularly watching for hypokalemia, low potassium, and hyponatremia, low sodium.
Why is monitoring potassium and sodium levels so critical with diuretics? I mean, besides them just being electrolytes.
Because while these medications are very effective at removing excess fluid and sodium, the process in the kidneys often leads to increased excretion of other important electrolytes, especially potassium with thiazide and loop diuretics. Low potassium, hypokalemia, can cause muscle weakness, cramps, and significantly dangerous heart rhythm abnormalities.
Ah, the heart rhythm connection.
Exactly. And low sodium, hyponatremia, can cause confusion, seizures, and even swelling of the brain in severe cases. Maintaining electrolyte balance is just vital for overall cellular function, including nerve impulses and muscle contraction, especially heart muscle function.
Okay, so that covers the mechanisms, classifications, causes, damage, lifestyle management, and specific medications based on your source. But the source highlights one absolutely non-negotiable critical action before giving any BP medication.
Yes, it states in no uncertain terms, always get a BP prior to giving a BP medication. Caps and everything right.
Yeah, it seems so obvious when you say it out loud, but why is this rule so paramount in clinical practice?
The reason is straightforward, but vital for patient safety. These medications are intended to lower blood pressure. If a patient's current blood pressure is already lower than usual, maybe due to other factors or just natural fluctuation, giving a dose could drop their pressure too low.
Causing problems.
Right. Leading to symptomatic hypotension, dizziness, lightheadedness, fainting, increased risk of falls, reduced blood flow to vital organs, what we call hypoperfusion, or even shock. You must know the starting point, the current BP, to safely decide if the medication is needed right now and if it's likely to be tolerated without causing harm.
It's the first line of defense against unintended consequences. Beyond this crucial check, what other assessment and diagnostic approaches does your source list for hypertension?
Well, monitoring BP trends over multiple readings and over time is essential. One high reading doesn't necessarily mean hypertension. Lab work is key, including the electrolytes we discussed, especially if on diuretics, and those BU and creatinine levels to assess kidney function, one of those critical target organs.
And looking for the damage itself.
Yes, assessing directly for signs of target organ damage, looking for hypertensive changes in the eyes during an eye exam, evaluating for LVH, which can often be seen on an ECG or an echocardiogram, and monitoring those kidney function labs we just mentioned.
So it's a combination of measuring the pressure, looking at blood markers, and examining the organs most at risk. Now let's circle back to that alarming number, the hypertensive crisis, over 1-800-NMON-23.
Right. Your source points out that this often occurs in patients who have stopped taking their blood pressure medications or whose hypertension is just poorly controlled.
The danger, as you mentioned earlier, is the potential for rapid organ damage. What symptoms might a patient experience in this state, according to your source?
The source lists several: severe headache, dizziness, epistaxis, that's a nosebleed that might be hard to stop, significant anxiety, blurred or double vision due to changes in the eyes, various neurological symptoms like weakness or confusion, and chest pain or shortness of breath if the heart is being acutely stressed. These are all red flags.
Signs that organs are really feeling that pressure.
Exactly. And the intervention principle is critical. While you need to lower the pressure, it must be done slowly. Your source mentions a target of reducing mean arterial pressure, or MAP, by no more than 25% in the first 2 to 6 hours.
Why slowly? It seems counterintuitive if the pressure is dangerously high.
It does, but it's vital. As we touched on earlier, if blood pressure, particularly in someone who has been hypertensive for a long time, is lowered too rapidly, the body's autoregulation mechanisms, like how it controls blood flow to the brain, can be disrupted. This can lead to hypoperfusion, not enough blood flow paradoxically, causing a stroke, an ischemic stroke, or worsening kidney injury.
Wow. So trying to fix it too fast can cause other major problems.
Precisely. Emergency drugs for hypertensive crisis are typically given intravenously, IV, in a controlled environment like an ICU, allowing for very precise titration, very careful adjustment to achieve that gradual reduction.
Wow. So hypertension isn't just a number. It's a complex interplay of systems with significant long-term consequences and potential acute emergencies. That wraps up our deep dive into the pressure side of things.
Understanding how pressure affects the vascular system and organs provides a crucial foundation for our next topic: Conditions like chronic hypertension and coronary artery disease, which we'll discuss shortly, often stress the heart in ways that can disrupt its electrical timing, leading to dysrhythmias.
Right. So let's shift gears from the plumbing and pressure to the heart's electrical system and how it can go wrong based on your sources. And the core concept for this entire section highlighted in your material is perfusion.
Absolutely. Everything the heart does, electrically and mechanically, serves the ultimate goal of maintaining adequate blood flow or perfusion to deliver oxygen and nutrients to every cell in the body. If the heart's rhythm is erratic, too fast, or too slow, its ability to pump effectively is compromised and perfusion suffers. Simple as that.
Your source also lists interrelated concepts like fluid and electrolyte balance, which makes sense given that electrical activity relies on those ions, right? And clotting, because irregular rhythms can increase the risk of blood clots.
Exactly. The heart muscle cells generate and conduct electrical impulses through the controlled movement of charged particles, ions, primarily sodium, calcium, and potassium, across their cell membranes. It's all about ion shifts.
Let's define the key electrical concepts from your source. What is depolarization?
Depolarization is described as the phase of electrical excitability. When a cardiac cell receives a stimulus, there's a rapid influx or efflux of ions that reverses the electrical charge across the cell membrane. This electrical change then triggers the mechanical response. The myocardial muscle contracts. Think of it as the on switch.
Okay, the electrical on switch and repolarization.
Repolarization is the recovery phase. Ions move back across the membrane to restore the cell's resting electrical charge. During repolarization, the myocardial muscle relaxes, preparing for the next electrical impulse and subsequent contraction. It's the reset.
On and reset, got it. Automaticity.
Automaticity is a unique property of certain specialized cardiac cells, like those in the SA node. It's their ability to spontaneously generate electrical impulses at a regular rate without any external trigger. It's the heart's intrinsic pacing function, its own little drummer.
And conductivity.
Conductivity is the ability of cardiac cells to transmit that electrical impulse rapidly and efficiently from one cell to the next throughout the heart muscle. This allows for the coordinated depolarization, the contraction of the atria and ventricles, passing the message along.
So the lexical events depolarization and repolarization enable the mechanical function, contractility.
Precisely. Contractility is the mechanical ability of the myocardial muscle fibers to shorten and pump blood in response to that electrical stimulation. The electrical impulse is the spark that ignites the mechanical squeeze. One has to happen for the other to follow.
Now, how does that electrical impulse travel through the heart in a normal, organized way? Your source maps out the conduction system, the heart's electrical highway. Where does it start?
It begins in the sinoatrial, or SA, node, located up in the right atrium. Your source correctly identifies this as the heart's primary pacemaker because it typically generates impulses at the fastest rate, normally 60 to 100 beats per minute. On an ECG, the electrical activity of the atria depolarizing, initiated by the SA node, is represented by the P wave.
Okay, P wave is the atria firing. From the SA node, the impulse spreads across the atria and converges at the AV junction.
Yes, the atrioventricular, or AV junction, which includes the AV node and the bundle of His. There's a crucial delay at the AV node. Your source mentions the PR segment on the ECG reflects this delay.
Why the delay?
This brief pause allows the atria time to finish contracting and completely empty their blood into the ventricles before the ventricles are stimulated to contract. This final push from the atria is sometimes called the atrial kick, contributing significantly to ventricular filling, maybe 20–30% of the volume.
Ah, gives the ventricles time to fill up properly. Then the impulse races down the bundle of His, splitting into the right and left bundle branches.
Correct. And finally, it spreads rapidly throughout the ventricular muscle via the Purkinje fibers. Your source specifically notes the Purkinje fibers are responsible for rapid conduction within the ventricles. Super fast.
Why is that rapid conduction in the ventricles so important for perfusion? You mentioned speed?
Because the ventricles, especially the thick-walled left ventricle, are responsible for the main pumping force that sends blood to the lungs and the rest of the body. To be effective, the entire mass of the ventricular muscle needs to contract nearly simultaneously, a coordinated squeeze. The rapid conduction through the Purkinje fibers ensures this synchronized contraction, maximizing the volume of blood ejected with each beat and maintaining adequate cardiac output and thus perfusion.
Okay, that's the normal electrical sequence. What does a healthy rhythm look like on an ECG, according to your source? Normal sinus rhythm.
Normal sinus rhythm, yes. Your source describes it as having a heart rate between 60 and 100 beats per minute, a regular rhythm with consistent spacing between beats, and a distinct P wave present before every QRS complex, with all the P waves looking similar, originating from that SA node.
Yeah.
Consistent and predictable.
What about sinus arrhythmias? Is that dangerous?
Your source mentions that in sinus arrhythmia, the rhythm originating from the SA node is irregular, often varying slightly with breathing, but the heart rate is usually still within the normal 60 to 100 BPM range. A key point your source makes is that these are usually asymptomatic. Most people are unaware they have this slight irregularity.
So an irregular rhythm isn't automatically a major crisis if the rate and overall function are okay. What about when the rate is the issue, starting with sinus tachycardia? Tachy meaning fast.
Right. Sinus tachycardia is simply a sinus rhythm where the heart rate is faster than 100 beats per minute. Your source notes it's often a response to something: medications, dehydration, hypovolemia, low blood volume, fever, pain, anxiety, etc. Symptoms, if they occur, can include palpitations, dizziness, shortness of breath, SOB, chest pain, or syncope, fainting, particularly if the rate is very fast and reduces the time the heart has to fill between beats.
Your source notes the QRS is shortened in sinus tachycardia.
Yeah.
That seems unusual. Usually the QRS duration stays the same, doesn't it?
Yes, that's a good point. Typically, in sinus tachycardia, the interval between beats is shortened due to the faster rate, making the whole cycle quicker. But the QRS duration itself, reflecting ventricular conduction time, usually remains normal because the pathway through the ventricles isn't affected. However, your source specifically highlights that the QRS is shortened in this rhythm description. So we stick with what your material says.
Okay, noted. A specific point from the source material. What about sinus bradycardia? Brady meaning slow.
This is the sinus rhythm with a heart rate slower than 60 beats per minute. Your source correctly notes it can be normal for well-conditioned athletes whose hearts are very efficient, or it can be caused by conditions that stimulate the vagus nerve, like vomiting, bearing down during a bowel movement, or certain medications like beta blockers.
Can it cause symptoms?
Like sinus arrhythmia, it can be asymptomatic. But if the rate is too slow to maintain cardiac output, symptoms can definitely occur, including syncope, dizziness, chest pain, or shortness of breath.
And again, those symptoms tie directly back to our core concept, poor perfusion. If the heart is beating too slow, it can't pump enough blood to meet the body's demands.
Precisely. And your source mentions artifact, which is just electrical noise or patient movement that distorts the ECG tracing, but isn't a true heart rhythm abnormality. It's important to recognize so you don't mistake it for a dangerous rhythm, like if someone's brushing their teeth while hooked up.
Right, gotta filter out the noise. Okay, let's move beyond the SA node and look at dysrhythmias originating in the atrial dysrhythmias, supraventricular tachycardia, or SVT.
Your source describes SVT as a rapid heart rate, typically much faster than sinus tachycardia, often between 150 and 280 beats per minute. It originates above the ventricles, hence supraventricular, and is often caused by an accessory pathway, an extra abnormal electrical connection that bypasses the normal AV node delay, allowing impulses to re-enter and cycle rapidly, like a short circuit.
A short circuit, that makes sense. Your source notes that paroxysmal SVT is particularly frustrating. Why?
Because paroxysmal means it starts and stops suddenly and unpredictably. You could feel fine 1 minute, then suddenly your heart is racing at 200 beats per minute, and then just as suddenly, it stops. Makes it hard to catch on an ECG sometimes, and hard to manage.
What interventions does your source list for SVT?
The initial step is always assessment check for symptoms and try to identify a cause. Your source stresses the danger if not resolved, highlighting the risk of cardiovascular deterioration due to the extreme rate reducing filling time and efficiency. If the patient is symptomatic but stable, vagal maneuvers are often the first line.
Like?
Techniques like the Valsalva maneuver, bearing down like you're having a bowel movement, or carotid sinus massage, although your source specifies carotid massage should only be performed by a physician. These try to stimulate the vagus nerve to slow conduction through the AV node.
What if those don't work, or the patient is unstable?
If vagal maneuvers are ineffective or the patient is unstable, your source lists synchronized cardioversion delivering a timed electrical shock to reset the heart's electrical system. For medications, adenosine is noted as a drug specifically used to terminate acute SVT episodes by briefly blocking conduction through the AV node. It chemically resets the heart, essentially.
Oh.
Yeah, it causes a brief pause, which can feel scary but is often effective. Calcium channel blockers and beta blockers are also listed as medications used to slow the heart rate by affecting conduction through the AV node, more for ongoing control.
Got it. Now, perhaps the most common dysrhythmia, explicitly noted as such in your source, atrial fibrillation, or AFib.
AFib is extremely prevalent, especially as people age and with underlying heart conditions. Your source associates it with structural changes in the atria, like atrial fibrosis and loss of muscle mass, and notes it's common in patients with hypertension, heart failure, and coronary artery disease. Basically, conditions that stress or damage the atria.
And the defining characteristic on the ECG, according to your source, NO-PUHE, why no P wave?
Correct. In AFib, instead of a single impulse from the SA node controlling things, there are multiple chaotic electrical impulses originating randomly throughout the atria. The atria aren't contracting effectively. They're essentially just quivering electrically and mechanically. This chaotic activity results in no organized P waves on the ECG, just a fibrillating baseline and irregular, often rapid, impulses getting conducted down to the ventricles whenever one happens to hit the AV node right.
What's the major consequence of this quivering instead of contracting, losing that organized push?
As your source notes, you lose the organized atrial contraction, that atrial kick we talked about. This atrial contraction normally contributes about 20–30% of the blood filling the ventricles just before they pump. Without it, cardiac output can decrease by that amount.
Which can cause symptoms.
Yes, it can lead to symptoms like fatigue, shortness of breath, palpitations, or reduced exercise tolerance depending on how fast the ventricles are going and the individual's underlying heart health.
And there's a significant risk associated with AFib, highlighted by the need for anticoagulation. Clots, right?
This is a critical complication your source emphasizes. Because the atria are quivering and not emptying effectively, blood can pool and become stagnant in the atrial chambers, particularly in a little pouch called the left atrial appendage. Stagnant blood is prone to forming clots.
And if a clot breaks free?
If a clot breaks free, it can travel through the circulation to the brain, causing a devastating stroke, or it could go to other parts of the body, like a leg or an organ. Therefore, long-term anticoagulation, blood thinners, are often necessary for patients with chronic AFib to prevent these thromboembolic events. Stroke prevention is key.
Your source lists warfarin as a common anticoagulant and also mentions DOACs, direct oral anticoagulants.
Yes, warfarin has been used for decades but requires regular blood monitoring, INR checks. DOACs are newer agents like Eliquis or Xarelto that are often simpler to manage, as mentioned in your material, often without needing the frequent blood tests. Your source also notes using an echocardiogram, an ultrasound of the heart, before procedures like cardioversion to make sure no clots are present in the atria that could be dislodged by the shock.
Makes sense. Safety first. What other interventions does your source list for managing AFib?
Management focuses on two main goals: controlling the heart rate, rate control, and restoring a normal rhythm, rhythm control, and preventing those clots. Medications listed include calcium channel blockers like diltiazem for rate control by slowing conduction through the AV node.
Slowing down how many chaotic beats get through.
Exactly. Beta blockers also for ventricular rate control. Potassium channel blockers like amiodarone are often used for rhythm control, trying to restore and maintain normal sinus rhythm, especially in more difficult cases. And digoxin is listed primarily for rate control, particularly in patients who also have heart failure.
And procedures beyond cardioversion.
Your source lists cardioversion, yes.
Yeah.
Also, radiofrequency catheter ablation, where they go inside the heart with catheters and use heat or cold energy to destroy the abnormal electrical pathways causing the chaotic activity. Biventricular pacing is mentioned, a type of pacemaker used for specific pacing issues, sometimes seen in complex heart disease associated with AFib, and procedures like the Watchman implant or left atrial appendage closure devices, which mechanically seal off that left atrial appendage pouch to prevent clot escape.
So they block off the area where clots usually form.
Exactly, offering an alternative to long-term anticoagulation for some patients who might be at high risk of bleeding, for example.
So AFib is complex, requiring a strategy to control rate, rhythm, and crucially, stroke risk. Now let's move down into the ventricles. Your source makes a very stark and important statement. Ventricular dysrhythmias are more life-threatening than atrial dysrhythmias. Why is that distinction so critical?
The reason is directly related to perfusion. Back to our core concept. The ventricles, especially the left ventricle, are the primary pumping chambers responsible for ejecting blood to the lungs and the systemic circulation, the whole body. If the ventricles are not contracting effectively, little to no blood is pumped out of the heart.
So no blood flow to the brain, the organs.
Exactly. Tissues and organs throughout the body are not receiving oxygenated blood, leading to rapid system failure. Ventricular function is absolutely paramount for sustaining life. Problems here are often immediately dangerous.
That makes the stakes much higher. Let's start with premature ventricular contractions, or PVCs. Those extra beats.
PVCs are early electrical impulses originating from an irritable focus within the ventricular muscle itself, disrupting the normal sequence. On an ECG, they appear as early, wide, and often bizarre-looking QRS complexes because the electrical activation of the ventricles is abnormal, not following the usual highway.
Your source notes they can occur as single beats or in patterns.
Yes, they can occur as single isolated beats, in pairs, couplets, every other beat, which is called bigeminy, every third beat, trigeminy, or in runs of 3 or more in a row, which is technically considered non-sustained ventricular tachycardia.
And your source points out that the compensatory pause after a PVC is a distinguishing feature.
Yes, after the early ventricular beat fires, the heart's normal pacemaker usually gets reset, and there's typically a pause before the next normal beat occurs. While isolated PVCs can be benign, quite common actually, your source correctly highlights the danger. Frequent PVCs or certain patterns could lead to more serious, life-threatening ventricular rhythms like VTach or VFib.
And the source gives a crucial instruction here.
Yes. Correct, the underlying issue. PVCs are often triggered by underlying problems like electrolyte imbalances, particularly low potassium or magnesium hypoxia, low oxygen, stress, caffeine, alcohol, or underlying heart disease. Addressing the root cause is key to reducing PVC frequency and the risk of escalation. Don't just treat the PVC, find out why it's happening.
Good point. Next up, ventricular tachycardia, or VT, or VTach.
Ventricular tachycardia is a rapid, potentially regular rhythm originating from an irritable site or circuit in the ventricles, usually at a rate of 140 to 180 beats per minute, or even faster. Your source describes it as essentially an electrical malfunction, causing the ventricles to contract too rapidly and often inefficiently. They're beating fast, but maybe not filling or pumping well.
And the absolutely crucial distinction here, you mentioned this earlier, is whether or not the patient has a pulse.
This is the decision point that dictates immediate intervention. Your source makes it clear. If the patient is an unstable VT without a pulse, it is treated as a cardiac arrest. That means immediate CPR and defibrillation.
No pulse means no perfusion.
Exactly. If the patient is in VT with a pulse, they may still be very unstable, maybe dizzy or having chest pain, but they are not in full cardiac arrest. The treatment in that case, according to your source, is typically synchronized cardioversion. Still an emergency, but different immediate actions.
And the warning.
Your source also warns that VT, especially if untreated, can escalate to ventricular fibrillation. It can degenerate into chaos.
Which leads us to the ultimate electrical emergency, ventricular fibrillation, or VFib. Your source calls this an emergency, full stop, in caps.
VFib is electrical chaos in the ventricles. Instead of organized electrical impulses leading to effective contraction, there are multiple, rapid, chaotic electrical signals firing off everywhere. This causes the ventricular muscle to simply quiver or fibrillate rather than pump blood. Mechanically, there is no coordinated contraction and therefore no cardiac output, zero perfusion.
It's just twitching uselessly. What are some potential causes listed in your source?
Causes listed include acute myocardial infarction, a heart attack, untreated or escalating to VT, severe electrolyte imbalances again, low potassium and magnesium are major culprits, hypothermia, hemorrhage, drug overdose, or significant trauma. Basically anything that severely stresses or damages the heart muscle electrically.
And the intervention for VFib, there's only one priority.
Your source is unambiguous. Immediate CPR with immediate defibrillation. Every second counts because without blood flow, irreversible brain damage begins within minutes. Defibrillation is the definitive treatment to stop the electrical chaos and hopefully allow a normal rhythm, like from the SA node, to resume. Shock the chaos.
Finally, ventricular systole, also an emergency, the flatline.
Yes. This is often called the flatline rhythm or ventricular standstill. On the ECG, there is a complete absence of any ventricular electrical activity, just nothing.
And clinically, what does this look like? What would you see?
Your source states clearly the patient will have zero blood pressure, zero pulse, and zero respirations. There is no cardiac activity supporting life at all.
And the intervention. Can you shock this?
No. Immediate CPR following the ACLS, Advanced Cardiovascular Life Support algorithm. Your source mentions epinephrine as a key medication administered during resuscitation to try and stimulate some electrical activity, maybe get something going that you could shock later. But a crucial point your source makes about a systole. You cannot shock someone out of a systole. Defibrillation delivers an electrical current to reset chaotic or excessively fast electrical activity, like in VFib or pulseless VTach. With no electrical activity present in a systole, there is nothing for the defibrillator to reset. Shocking a flatline doesn't do anything helpful.
That's a vital distinction. Defibrillation is not used for a flatline. It's used to stop harmful present electrical activity.
Agree.
Speaking of defibrillation, your source includes important safety points.
Yes, patient and rescuer safety during defibrillation is paramount. Your source lists crucial steps. Ensuring the area around the patient is clear before delivering the shock. I'm clear, you're clear, everybody's clear.
Right.
Making sure the patient's skin is dry and removing any medication patches, like nitroglycerin patches, from the chest to prevent burns and ensure proper electrical conduction. Donning appropriate PPE, strictly following ACLS protocols for the sequence and energy levels, and meticulously documenting the time the shock was delivered and the heart rhythm immediately before and after are all highlighted.
Good reminders in a high-stress situation. Your source also provides a summary of some key medications used for dysrhythmias, building on some we've mentioned.
Yes, a brief overview. Sodium channel blockers like lidocaine are specifically noted for their use in treating ventricular dysrhythmias. Beta blockers like metoprolol are used for rate control in rhythms like AFib, atrial flutter, and SVT. Potassium channel blockers like amiodarone are listed for more difficult-to-treat rhythms like AFib and ventricular tachycardia, often for rhythm control. Calcium channel blockers like diltiazem are key for ventricular rate control in AFib. And as we emphasized, anticoagulants like warfarin and DOACs are essential for preventing devastating blood clots in patients with AFib.
So these medications target different aspects of the heart's electrical conduction or the resulting clot risk. Finally, what are the key clinical priorities your source outlines when managing patients with dysrhythmias? What do you need to watch?
Continuous monitoring is number one, specifically monitoring ECG rhythm strips to identify the rhythm and track its response to interventions. But equally important and directly linked to the core concept is assessing for changes in perfusion. Is the rhythm, whatever it is, actually delivering blood effectively?
How do you assess for whether the body is getting enough blood flow despite the rhythm issue? What are the signs?
Your source lists key indicators. Checking capillary refill time, how quickly color returns to the fingernail bed after pressing it. Evaluating level of consciousness, LOC, for signs of reduced blood flow to the brain, confusion, drowsiness. Monitoring blood pressure, BP. And checking the quality and presence of peripheral pulses. If these are abnormal slow cap refill, altered LOC, low BP, weak pulses, it's a strong sign that the rhythm is compromising the heart's ability to pump effectively.
And labs.
Lab work is also critical, especially monitoring electrolytes like potassium K+, and magnesium Mg2+, as these are absolutely vital for stable cardiac electrical activity. Digoxin levels are monitored if that medication is being used, as it has a narrow therapeutic window.
That's a comprehensive look at the heart's electrical system and the rhythms that can cause problems, from relatively benign to immediately life-threatening. We've explored pressure and electricity. Now let's bring it all together by looking at the heart muscle itself and the blood vessels that feed it. Acute coronary syndromes, or ACS.
Right. ACS represents a spectrum of conditions where there is a sudden reduction or complete blockage of blood flow to the heart muscle. It's often the dramatic culmination of underlying issues like hypertension and high cholesterol damaging the coronary arteries over time. And as we just discussed, ACS can also be a trigger for dangerous ventricular dysrhythmias because the damaged or oxygen-starved heart muscle gets electrically irritable.
It all connects. Your source describes ACS as encompassing several different scenarios, a spectrum, you said.
Yes, ranging in severity. It starts with angina pectoris, which is chest pain due to reduced blood flow. Your source differentiates between stable angina and unstable angina.
Stable angina is predictable, right? Occurs with exertion, relieved by rest or nitroglycerin.
Correct. It's typically caused by a fixed blockage, maybe plaque buildup, in a coronary artery that limits blood flow only when the heart's oxygen demand increases, like during exercise or stress. It's like a warning signal. The heart's telling you it's not getting quite enough when you push it.
Unstable angina is more concerning. Much more.
Much more. Your source states unstable angina occurs at rest or with minimal exertion, is unpredictable, is often more severe or lasts longer, and is not easily relieved by rest or nitroglycerin. This usually signifies a worsening blockage or a plaque that has become unstable and is maybe beginning to rupture, forming small clots. It indicates the heart muscle is at higher risk of damage even at rest. It's a big red flag for an impending heart attack.
And then the actual heart attacks, the myocardial infarctions, MI, where muscle damage occurs, and STEMI and STEMI.
And STEMI stands for non-ST elevation myocardial infarction. In this case, there is actual damage or death to heart muscle tissue, an infarction indicated by elevated cardiac enzymes released into the bloodstream. things like troponin.
The markers we talked about.
It's exactly. However, the ECG does not show the characteristic ST segment elevation. This typically means the blockage is significant enough to cause damage, but maybe not a complete sustained occlusion of a major artery, or maybe it affects a smaller area.
And STEMI, the big one.
STEMI stands for ST elevation myocardial infarction. This is the most serious type of heart attack described in your source. It is almost always caused by a sudden complete occlusion, a total blockage of a major coronary artery, usually by a blood clot forming on a ruptured plaque. The critical indicator on the ECG is the distinctive ST segment elevation, which reflects transmural injury damage through the entire thickness of the heart muscle wall.
And your source emphasizes that a STEMI requires
Immediate PCI percutaneous coronary intervention.
like an angioplasty or stenting to physically open the blocked artery. Why is that immediate aspect so crucial for STEMI?
Because with a complete blockage of a major artery, heart muscle is dying rapidly. The longer the artery remains blocked, the larger the area of permanent muscle damage. Your source's emphasis on immediate PCI reflects the critical principle of time is muscle. The faster blood flow is restored, the more heart muscle can be salvaged, which directly impacts long-term heart function and survival. The goal in hospitals is to get that artery opened within a certain time frame from when the patient arrives, often referred to as door-to-balloon time. Every minute counts.
So ACS is a spectrum from a warning sign like stable angina to unstable angina, which is alarming, to STEMI, where there's damage but maybe not full blockage, to STEMI, the full blockage needing immediate opening. Similar to hypertension, your source highlights risk reduction strategies for ACS.
Yes, and there's significant overlap because the underlying process, often atherosclerosis or plaque buildup, is driven by similar risk factors. Controlling modifiable risk factors is paramount. Managing existing hypertension, high-pressure damages arteries, making them prone to plaque.
Makes sense.
Controlling high cholesterol is a key component of those plaques. And managing diabetes accelerates vascular damage significantly.
And the familiar lifestyle pillars, still important here.
Absolutely essential. Smoking cessation. Smoking severely damages blood vessels and promotes clotting, so quitting is huge. Adopting a healthy diet, like the DASH diet or similar heart-healthy plans low in saturated fats, and getting regular exercise. Your source also lists medication adherence, consistently taking prescribed preventive medications like daily low-dose aspirin to prevent clot formation, statins to lower cholesterol and stabilize plaques, and beta blockers to reduce cardiac workload and stress.
What are the key medications used during an acute ACS event itself, based on your source, when someone is actually having the heart attack or unstable angina?
In the acute phase, medications are used rapidly to limit damage, restore blood flow if possible, and reduce the heart's workload. Aspirin is given immediately, usually chewed, to quickly inhibit platelets and prevent the blood clot in the coronary artery from getting larger. Nitroglycerin, nitro, often given under the tongue, is used to cause vasodilation in the coronary arteries, potentially improving blood flow, and it also reduces the heart's workload, helping relieve chest pain.
And morphine, is that just for pain?
Morphine is used for pain relief in ACS, which is important, but it also has beneficial hemodynamic effects. It causes some vasodilation, which helps reduce preload and afterload, the amount of blood returning to the heart, and the resistance the heart pumps against. This decreases the heart's oxygen demand, which is helpful when supply is limited.
Beta blockers again, used acutely.
Yes. Often started early in ACS, maybe intravenously or orally, to slow the heart rate and reduce the force of contraction, thereby lowering the heart's oxygen demand and potentially limiting the size of the infarct, the area of damage. Statins are also typically started acutely, even if cholesterol levels aren't known yet.
Why start statins right away?
Beyond lowering cholesterol long-term, statins have anti-inflammatory properties and are thought to help stabilize the unstable plaques in the coronary arteries, making them less likely to rupture further.
And heparin?
Heparin, or sometimes other anticoagulants, is given acutely, usually intravenously, to prevent further clot formation or growth in the affected coronary artery or elsewhere in the circulation while waiting for definitive treatment like PCI, or if PCI isn't an option.
So it's a multi-pronged pharmacological attack: stop the clot, improve blood flow, reduce the heart's work, calm inflammation, and manage pain. What are the assessment priorities and diagnostics your source emphasizes during a suspected ACS event? What do you look for first?
Assessment priorities are rapid and focused. Getting an ECG immediately, within minutes of arrival ideally, to look for those telltale changes like ST segment elevation, or depression, or T wave inversion, which indicate myocardial injury or ischemia.
And blood tests.
Serial blood tests for cardiac enzymes, specifically troponin I, or T, and sometimes CKMB, are critical. These proteins are released into the bloodstream when heart muscle cells are damaged or die. Rising levels confirm a heart attack.
They are the definitive markers of actual muscle damage.
Exactly. Also, monitoring vital signs continuously, assessing the patient's oxygenation status, do they need supplemental oxygen, and a detailed pain assessment, asking about the location, quality, crushing, tight, pressure, severity, duration, and any radiating pain, like to the arm or jaw, is crucial to evaluating the situation and how it's changing. These assessments guide the diagnosis: STEMI, NSTEMI, unstable angina, and the urgency of intervention.
And what about critical care management and potential complications listed in your source? What are the big worries after the initial event?
Patients with ACS require close monitoring, usually in a critical care setting like a CCU or ICU initially. Monitoring for arrhythmias is absolutely essential because damaged or ischemic heart muscle is electrically unstable and prone to dangerous rhythms, especially those ventricular ones we discussed, like VT or VFib. That's a major cause of death early on.
Okay, watching the rhythm closely. What else?
Monitoring for the development of cardiogenic shock, where the heart is simply too damaged to pump enough blood to support the body's needs, or heart failure due to significant muscle damage, reducing the pump function long term. These are severe complications.
And if the patient undergoes PCI, like a stent placement, what's the focus after that procedure?
Your source lists important post-procedure care points for PCI. Meticulously monitoring the catheter insertion site, often in the groin, femoral artery, or wrist, radial artery, for bleeding or hematoma formation. Assessing for signs of bleeding elsewhere, because they're often on potent anticoagulants. And critically, assessing pulses below the insertion site in the foot if the groin was used, or the hand if the wrist was used, to ensure blood flow to the extremity hasn't been compromised by the procedure or complications at the site.
Checking circulation downstream.
Exactly. And having emergency equipment readily available at the bedside just underscores that even after successful intervention, these patients remain potentially unstable and at risk for complications.
And finally, your source touches on the critical phase of care coordination and transition as patients recover from these serious cardiac events and prepare to go home or to rehab.
This is where the focus shifts to long-term recovery and prevention, right? It's about helping people get back to their lives safely.
Precisely. It's about transitioning from acute care back towards normal life while managing the condition. Points mentioned in your source include device education, if a pacemaker or maybe an implantable defibrillator, ICD, was implanted for a dysrhythmia.
Learning how it works, when to get it checked.
Right. Strict anticoagulation monitoring is necessary if the patient is on medications like warfarin, especially after certain procedures, or for chronic AFib, making sure the blood thinning level is just right. Cardiac rehab referral is a cornerstone of recovery after ECS. These structured programs provide supervised exercise, education on diet and meds, and crucial psychosocial support to help patients regain strength and confidence.
Building back physical and mental health.
Follow up with specialists is key too.
Yes, ongoing care with a cardiologist or other specialist is vital for medication management, monitoring progress, adjusting treatment, and detecting potential issues early. And importantly, home monitoring and symptom education, empowering you, the listener, to track your blood pressure at home, recognize warning signs of worsening symptoms, like changes in chest pain patterns or new shortness of breath or palpitations, and know when and how to seek medical help. That self-management piece is a massive part of preventing future events and living well with these conditions.
This has been a truly comprehensive deep dive into a crucial stack of material you provided. We've gone from the fundamental mechanics and silent threat of hypertension, exploring how pressure impacts the entire system, and the key points for management in crisis. We then shifted to the heart's intricate electrical system, understanding how dysrhythmias arise from electrical issues and how they compromise that vital concept of perfusion, covering everything from, relatively benign irregularities to immediately life-threatening ventricular chaos and their management.
And finally, we tackled acute coronary syndromes, the potentially dramatic consequence of damaged arteries, understanding the spectrum from stable warnings to immediate life-threatening heart attacks, and the critical assessments and interventions involved. We've really pulled apart the key insights your sources offered on these interconnected aspects of adult heart health.
Hopefully, this deep dive has helped clarify these complex topics, making them feel less daunting and more understandable. drawing directly from the information you shared with us. Thank you for bringing this material to us and taking this journey of exploration with us today.
It's incredibly valuable to engage with this kind of targeted information. Really helps connect the dots.
And as we wrap up this deep dive, here's a thought for you to mull over, pulling together some threads from our conversation today. Considering how many critical heart issues we discussed, from elevated blood pressure, which is often silent, to potentially silent arrhythmias, to even unstable angina, which can be a subtle warning, can exist without obvious, unmistakable symptoms until significant damage or an acute event occurs. What does this deep dive make you think about the role of regular checkups, preventive measures, and maybe really tuning into the subtle signals your body might be sending, even if they don't seem like a big deal at the time?
That's a vital reflection. Proactive health and awareness truly are your best allies when it comes to conditions like these. Listening to your body and getting things checked out.